This presentation will be on lipid regulating drugs. I have tried to simplify this lecture and make it as short as possible. So in this section, you'll probably get an MCQ or an SAQ very rarely, okay? So what's important, you have to focus on the drugs that are being used commonly, their mechanisms of action, few important contraindications, and a few side effects, okay? So in order to understand all this, we need to have a good understanding of the basics, okay? Not very detailed, but just the basic understanding of what we have learned in pre-clinicals would be fine. So let's start with lipoproteins. So what are lipoproteins? These are basically amphiphilic protein lipid complexes, and they act as transport molecules to carry this lipids or like triacylglyceride, phospholipids, cholesterol, and cholesterol esters through your circulation. Okay, and what we need to know is that chylomicrons have a higher concentration of triacylglycerides. Okay, and same with VLDL and LDL have a lot of cholesterol within it. So LDL is called the bad cholesterol and HDL is called the good cholesterol. Why HDL is called the good cholesterol? Because it aids in basically takes up cholesterol from your periphery and bring it back to your liver. So that process is called the reverse transport. Okay, and LDL does the opposite. So it gives cholesterol to the periphery. In short, okay, that is what you need to know here, right? So a little bit of the bit about the cholesterol pool inside your liver. Okay. Now, how is this pool formed? It can either be through what you eat, so your dietary and biliary cholesterol, and de novo synthesis of cholesterol, that is cholesterol synthesis that happens within the your hepatocytes. I think in your endoplasmic reticulum. Okay. And cholesterol from extrahepatic tissues. That is basically what HDL brings. Or it can either be due to LDL, it can be due to LDL uptake as well. And how is this pool used up? It can be either used to synthesize bile acids, steroid hormones, vitamin D, and for endogenous lipoprotein pathways as well. Okay. Next, this is about the cholesterol synthesis. Now, I'm not going to talk about this in details, but 3 points that I want to highlight. First one is that HMG-CoA, can you say this? HMG-CoA, and then mevalonate is produced, and this reaction is catalyzed by HMG-CoA reductase enzyme, and this is the rate-limiting step, and this will be the rate-limiting enzyme. Okay, and the other thing is the precursors for acetyl-CoA. So can you see glycolysis, you get pyruvate, and then pyruvate becomes acetyl-CoA, enters the citrate or Krebs cycle, then gets and the citrate gets shunted out of the mitochondria and then gets reconverted to acetyl-CoA and then enters this cholesterol synthesis. So all these details are not necessary, but what you need to know is if somebody has a higher concentration of glucose in their circulation, then of course there's a higher risk of cholesterol synthesis. The third point is that you can also get acetyl-CoA through fatty acid oxidation, beta oxidation of fatty acids. So if somebody has a lot of free fatty acids circulating in their blood, then also you can get a lot of acetyl-CoA. Hence, it can promote cholesterol synthesis. Okay, those 3 points need to be understood. Okay. Next, right. Next is, I'm not going to go into details about atherosclerosis and the process of, and all, but what I want to highlight is that LDL can readily enter an artery. Okay, it can readily enter an artery, and this gets modified chemically. Now, this modified LDLs are pro-inflammatory. Okay, modified oxidized LDLs are pro-inflammatory. And we know in atherosclerosis, inflammation can initiate as well as, it can drive the whole process of atherosclerosis. Therefore, LDL is not only atherogenic, but it can also activate platelets, and it can be thrombogenic as well. Right. So what we need to understand from here is that if somebody has a higher LDL concentration in the body, the risks for atherosclerotic cardiovascular disease uh, uh, are high, right? Next, dyslipidemias. Dyslipidemias are basically disorders of lipoprotein metabolism. Okay, so you will have altered lipid levels. It can be either high total cholesterol, high LDL levels, or else that could be low HDL cholesterol, or else there can be high triglyceride levels. Now, the commonest are and sort of more important ones are high LDL and high tags, or you can have both as well. Right. So dyslipidemias are actually categorized into two. So primary dyslipidemia and secondary dyslipidemia. Primary dyslipidemia, it's about the genetics. Okay, those disorders are genetically determined. Secondary are consequence of another condition. So it can be either diabetes mellitus. So if you could recall what I spoke here, cholesterol synthesis, about having high glucose levels affecting your cholesterol synthesis, then you can understand how diabetes mellitus play a role here. Then what are the other ones? Hypothyroidism, alcohol consumption, chronic renal failure, certain drugs. These can cause secondary dyslipidemia. Right. Before going into the details about drugs used in dyslipidemia, I'll talk a little bit about this management. So what doctors do is they find the underlying cause. Okay, this is very short explanation. So they find out whether it's primary or secondary. Why? Because if it's secondary, you need to treat the underlying cause, right? So if it's hypothyroidism, then you probably start the patients on levothyroxine, something like that, right? So you find the underlying cause. Next, the commonest management is that you initiate dietary and lifestyle modification. Dietary in the sense like you can ask the patient to reduce the amount of saturated fat diet, or tell them what they need to control. And then you can ask the patient to reduce the amount of sugar intake, things like that. Okay, and then lifestyle modification. If the patient is obese, you can ask the patient to do more exercise and initiate weight control, anything to reduce their weight, or else you can ask the patient to quit smoking or reduce alcohol consumptions, things like that. Okay, then before starting on this drug therapy, you have to assess whether drug therapy would be useful for this patient, because say in type 1 hyperlipidemia, that is if the patient has higher chylomicrons level, there is no use of drug therapy. So what they stick to a diet control, and that is the main management there, okay, for these patients. Right. However, drug therapy can be essential for groups of patients like patients with atherosclerotic cardiovascular diseases. Okay, and if the patient has LDL cholesterol, if the patient has a very high level of LDL cholesterol, like say more than 190 milligram per deciliter, or else if the patient is diabetic. Okay, if there's diabetic mellitus, and along with diabetes, this person has high LDL as well, things like that. Okay, so groups of patients who have basically atherosclerotic cardiovascular disease, or they have those with the risk of cardiovascular disease, or as groups of people who have diabetes mellitus, these people, it's better if you start them on drug therapy. Okay, so it's essential there. Right. So as you can see, there are statins, fibrates, bile acid resins, niacins, inhibitors of cholesterol absorption, omega-3 fatty acids, and PCSK9 inhibitors. Out of this, I'm not going to talk about everything. And at the same time, I'll be focusing on more important ones like statins, probably fibrates, bile acid resins, niacin, not so important. Inhibitors, a little bit of these. Not so important. Yeah, so mostly I'll be focusing on statins, fibrate, resins, and ezetimibe. Okay, right. Why? Because they are commonly used, and the other thing is that the mechanisms of action is kind of important to do, right? So the first one would be statins. So right. So basically, statins, what are statins? They competitively inhibit HMG-CoA reductase. Can you see here? Yes, statins inhibit HMG-CoA reductase. So what are they doing? They're trying to inhibit the cholesterol synthesis. Now, right. Now just remember this. If cholesterol synthesis is reduced here, the de novo synthesis is being reduced by statins. Why? HMG-CoA reductase enzyme is inhibited, competitively inhibited. So what this mechanisms do, they try to compensate the reduction here by allowing more and more LDL uptake, or they try to take up cholesterol from the periphery. So they increase the LDL receptor levels. Okay. So if there's more LDL receptors, of course, there'll be more LDL internalization. LDL is the ligand and they bind to this receptor and they get internalized. Okay. So if there is more LDL receptor expressed here, there'll be more LDL uptake. So if you're clearing LDL, that is the bad cholesterol, you're reducing the cholesterol levels in your body as well. Okay. So that is the action, mechanism of action of statins. So they reversibly inhibit HMG-CoA reductase in the liver, and they also activate SREBP2, increases hepatic LDL receptor expression. Okay, this is the most important mechanism of action, right? So as you can see, what is the clinical usage? These drugs are actually first line for patients with increased atherosclerotic cardiovascular diseases. Okay. So indications basically, if a patient, you identify a patient of as having symptoms of metabolic syndromes, then you can initiate statins. So, for example, you perform a fasting blood glucose, and if the patient has more than 100 milligram per deciliter, then you can initiate statin. Or as the triacylglyceride is more than 150, BMI more than 30, obese basically. The patient has hypertension. These are some indications for statins. So why is it first line? What is so special about statins? They have some pleiotropic effects. What is pleiotropic? What are pleiotropic effects? These are additional effects. Okay, you don't predict this. So these are actions other than those which the drug was developed for. So they can stabilize atherosclerotic plaques, improve endothelial function, inhibit platelet thrombus formation, and they have vascular anti-inflammatory effects. You can read it here. Okay, right. So generally statins are well tolerated, and they can be they generally work well for all types of hyperlipidemia. Okay. However, note this: if a patient or if a patient has less LDL receptors, lesser number of LDL receptors genetically, I mean naturally, if he or she has a low number of LDL receptor, then this the effectiveness of statins will not be that great compared to normal people. Okay, because can you see this LDL receptor, there's less LDL receptor, this part of the mechanism would be sort of slowed down. Okay, so just note that patients who lack LDL receptors naturally will not benefit as much as the others do, right? A few about the pharmacokinetics. It's given orally, and there's extreme first pass metabolism. There are few exceptions, but I don't think it's very necessary. Next is it's better at night. Why is it taken at night? Is because these LDL receptors tend to show circadian rhythm, and they are expressed more in the nighttime. And the same thing goes with HMG-CoA reductase enzyme activity. They are kind of more active during the night. Okay, and statins they are going to be metabolized in by CYP450 liver enzyme and excreted through bile and feces. Why I'm going into pharmacokinetic details? Because statins are they are the most commonly used drugs. So it's better to just know these, okay? Right, so the adverse effect. Now remember, for all lipid regulating drugs, okay, mostly the commonest adverse drug effect that you can expect is any sort of GI disturbances. Okay, those are the commonest. Okay, so the same goes with statins. You will have dyspepsia, abdominal pain, diarrhea, etc. And in addition, there's a chance for hepatotoxicity. Okay, so it's essential that you evaluate your AST, ALT levels, and if your AST levels are more than 3 times the upper limit, so AST, there's a range, right? So if it's more than 3 times the upper limit, then of course it's better to stop the drug. Okay. And then there's a chance for myotoxicity, basically rhabdomyolysis. It's very rare, but it's common among patients who have renal insufficiency, hyperthyroidism, vitamin D deficiency, etc. And also the risks for this rhabdomyolysis are greater among those who are taking fibrates along with statins. The combined therapy of statins and fibrates are better to avoid because of this risk, myotoxicity. Okay, and of course angioedema, right? And so extra ones are like they can increase the effect of warfarin. So better to check your INR. Okay, and better to evaluate INR before initiating statin therapy. Yeah? And statins are of course contraindicated in pregnancy, lactation, and acute liver disease. Okay. It's better to know these. So again, I'll repeat, contraindicated in pregnancy, lactation, and acute liver disease. So if it's contraindicated in, say, in a pregnant women, then what are the alternatives? Okay. So before, right. So the alternatives would be bile acid resins, or as now that too is being replaced by ezetimibe. Okay. So let's go through some important facts about resins. That is resins, or in other words, you can call them bile acid sequestrants as well. Okay, right. Now this is a picture that that shows how lipids get absorbed. Okay, so if you can pause the video and go into this is quite this is quite in detail. So if you can pause the video and go through it, that would be better. But in short, so lipids or the products of lipid digestion are basically lipophilic. Okay, so now these lipids in our diet are digested by enzymes, so lipases, and they are emulsified, that is converted into smaller globules. So larger globules of this lipophilic compounds are hard to digest. They are also hard to absorb. So they're converted. They're converted into smaller lipid globules. Okay, that is the process is called emulsification by bile acids to facilitate absorption. Okay, so bile acids are the ones playing the major role here in emulsification. Okay, so these bile acids are basically, they are negatively charged. Okay, so can you see they just cluster around these small globules? Okay, so so the picture you get here is there is a negatively charged substance around the lipophilic substance. So that means they are basically, now they've turned them into amphiphilic. Okay, so right, so bile acid, which are negatively charged, cluster around the products of fat digestion, and they form small clusters called micelles. Okay, now these micelles get easily they can just they come into contact with this brush border of enterocytes, and they are transported. Okay, they are transported here. It's not shown, but they are transported through a protein called NCP1L1 transporter. Okay, it's a transporter protein. Why is it important? Because as you can see, there is another drug that will act here. I'll come up to that later. Okay, so right. So here, where does this resins come into play? What they do is they basically bind to this bile acids. They bind to this bile acid. Resins bind to this bile acid, form complexes, and they get easily excreted in the feces. Right. So so usually what happens is now the bile acid is secreted into the small intestine for emulsification purpose, right? So they return back to the liver through enterohepatic circulation. Okay, so resins prevent this because they are forming a complex and they are preventing the action, and they prevent this bile being reabsorbed as well. So resins prevent this, and as a compensation, more and more bile acids will be produced utilizing cholesterol. So if you could go into this, check this out. Now, if there's more and more bile acids are being produced by this cholesterol pool, because bile acids do not return to the liver, so the liver thinks you need more bile acids, so it starts producing bile acids using cholesterol. So can you say the liver cholesterol levels will start to decrease as they're being utilized? So what liver does is it can either increase all this process. Okay, now diet is of course something related to the person, individual person. So what happens is there can either be increased de novo synthesis of cholesterol, or else it can increase the LDL uptake, like what we learned in statins. Okay, right. So if you can ask me, so if there's more de novo synthesis of cholesterol, there'll be increased cholesterol levels. So that is pretty bad. Yes, it can be, but the thing is that this happens more than de novo synthesis. So the LDL uptake is more than the de novo synthesis of cholesterol. So the LDL clearance will be greater, so that in your circulation, the LDL cholesterol level will start decreasing. Okay, that is how statins act. Sorry, that is how bile acid resins act. Okay, so mechanism of action: binds non-covalently to bile acid and prevent bile absorption. Examples of drugs are like cholestyramine and cholestyramine, cholesevelam, etc. Okay. Right, two nice to know facts is that this cholesevelam, that is not mentioned here. So cholesevelam has glucose lowering effect. This is a nice to know fact. So if you want, you can skip. Okay, this has a glucose lowering effect and therefore prescribed for type 2 diabetes mellitus patients. And this cholestyramine over here, this reduces pruritus caused by accumulation of bile acid in biliary stasis. Okay, those are two nice to know facts. Then a little bit of pharmacokinetics taken orally. I mean, resins are taken orally, and patients usually hate resins because it's not it has a very bad taste. Okay, and it's not absorbed. It not therefore obviously it's not metabolized. It's just excreted in the feces. Okay, and the other thing, let's talk about the adverse drug effects. Of course, as I told you, all these lipid regulating drugs, they have something, some issue related to the GI system. So this is not an exception. It has bloating and dyspepsia. Okay, right. And the other important thing is now because of now I told you, right, it's blocking the bile acid action, so the fat absorption will be reduced as well. So we know that there are fat soluble vitamins as well, right? Vitamin A, D, E, K, right? So you can have, because of those reduced the reduced absorption of such vitamins, you can have like signs and symptoms indicating vitamin A, D, E, K's deficiency as well. But the important one is that resins, they can bind to several medications, okay, and reduce their absorption as well. For example, say digoxin, warfarin, fat soluble vitamins, as I told you before, right? The absorption of these things get reduced as well. Now, it's not mentioned here because it's a nice to know fact. Like those who are on levothyroxine, that is, what you take in hypothyroidism, right? So it's advised these patients should take levothyroxine 1 hour before or 4 to 6 hours after resins, after you take resins. Okay, right. So the next alternative. Okay, I'm sorry that this is a little too small. Right. So the next alternative for statins now is ezetimibe. So because patients hate the taste of resins, ezetimibe are coming into, they are playing the action as the alternative for statins. Okay. So basically what these do is, I told you before that, give me a second. Right. So the micelles get transported into the enterocytes through a transporter protein called this NCP1L1, right? Ezetimibe will inhibit these transporters over here. Okay. So yeah. So that way, so basically, these decrease the transport of micelles into the enterocytes by inhibiting that NCP1L1 transporter, right? So yeah, so that is the mechanism of action of ezetimibe, and so cholesterol absorption is reduced because you have cholesterol within the micelles. The micelles itself is not entering into the enterocyte, so you will obviously have reduced absorption of cholesterol. Okay, the maximum effect will be when you combine this with statin. So it's better for combined therapy with statins. Okay, right. So right. Right. So ezetimibe, so through yeah, so inhibiting cholesterol absorption, it can mainly decrease the cholesterol absorption up to about 50%, right? And therefore LDL cholesterol will reduce, and then it also reduces LDL incorporation into VLDL in liver, right? And I think I've told you that it's used better, it's combined with statins, right? And contraindication, basically they are contraindicated in moderate to severe hepatic insufficiency, right? Now, another set of drugs that can be prescribed to atherosclerotic cardiovascular disease patients who need additional LDL cholesterol lowering would be this PCSK9 inhibitors. Some examples are like alirocumab, evolocumab. By this name itself, like anything that any drug name that could end with MAB at the end suggests they are monoclonal antibodies. So of course, they are obviously expensive. Okay. Right. So what is this PCSK9 inhibitor? PCSK9? It's an enzyme. PCSK9 is an enzyme, and this enzyme degrades LDL receptors. Okay. So if this enzyme degrades LDL receptor after it, so if this enzyme degrades LDL receptors, LDL clearance is impaired. So any drug, if any drug that could target this enzyme and inhibit its action, means it's allowing LDL receptors to be expressed more. All right. So basically, by inhibiting PCSK9, we are allowing more and more LDL clearance to occur. Okay. Right. So that is all that you need to know about PCSK9 inhibitors. Next would be fibrates. And this is kind of important because fibrates are used to treat increased triglyceride levels. Okay, especially there's a disorder called dys-beta-lipoproteinemia, where there's increased ideal levels. That means ideal is what you get like, so first VLDL is released from your liver, and this has a lot of triglyceride, and there's this enzyme called lipoprotein lipase in your peripheries, being it like smooth muscle tissues, your blood vessels, your muscles, etc. So this lipoprotein lipase, this takes up the triglyceride from your VLDL into the peripheral tissues. So, so when this action continues, you'll be having a reducing level of triglyceride, and your cholesterol will be remaining. So, VLDL will become ideal, and then ideal, again the same process happens, will become LDL. Okay, that is that process. So if in these patients with dys-beta-lipoproteinemia, there will be an increased IDL level. Okay. So examples are gemfibrozil, clofibrate, fenofibrate, etc. Okay. Now the mechanism of action, these act through PPAR, that is peroxisome proliferator activated receptors. Okay, and these function, this PPAR function as nuclear transcription factors that enhance lipoprotein enzyme function. All right. So if LPL, that is lipoprotein lipase function is enhanced, that means there will be more and more take up of triacylglyceride from these lipoproteins into the peripheral tissue, that is skeletal muscle, adipose, etc. This means fibrates can increase your triacylglyceride clearance by about 20 to 50%. Okay. There are a few additional effects as well, which I'm not going to mention, which would be good to know, right? Okay, so there's increased expression of ApoA1 and A2. Therefore, there's a additional effect of HDL cholesterol to increase. Then it will inhibit ApoC3, increase free fatty acid oxidation in liver, and reduce triacylglyceride synthesis. So increasing free fatty acid oxidation in liver means it's preventing the chances or reducing the chances of cholesterol synthesis. And same thing goes with reduced triacylglyceride synthesis. Okay, right. So pharmacokinetics, there's high albumin binding, 9% renal elimination, so and rapid absorption with meal. Okay, so what you need to know is, if a patient has renal insufficiency, then better avoid fibrates. Okay. Yeah. So as usual, fibrates are also not an exception to GI disturbances, which is the commonest. So there'll be GI disturbances. Then there's this risk of formation of gallstones, especially with gemfibrozil. Okay, because it increases biliary cholesterol excretion, right? And there's a risk for myositis, myositis. Oh God. Okay, rhabdomyolysis. Basically, if you take it with, I mentioned that before itself, if you take this fibrates as a combination therapy with statins, then you have a risk for myositis. So better if a patient complains, say, of muscle pain, then better to evaluate their creatine kinase levels and adjust the dosage, or you might have to even stop the medicine. Right. And there's increased effect of warfarin. So evaluate your INR. Contraindicated, as I've already told you, contraindicated in renal dysfunction. Yeah. Next would be niacin. Okay, niacin is the usage of niacin has reduced a lot these days. Okay, so but it's important to know that it's the most, because it's the most effective drug to increase HDL cholesterol levels. Okay, and it can also be combined with statins. So at very high doses, it can simply inhibit lipolysis in adipose tissue. So if there is inhibition of lipolysis, that means free fatty acid production is reduced, right? So triacylglyceride synthesis will be reduced with reducing circulating free fatty acids. So there's less VLDL. If there's less VLDL, that means there's less LDL as well. Okay, and it can be used if there's severe hypertriglyceridemia with pancreatitis, that is severe form of increased triacylglyceride level, and if it's not responding to treatments, other treatments like say fibrates, if it's not responding, you can suggest niacin. Adverse drug effects is flushing and pruritus. Yeah, these two are the most important ones: flushing, pruritus, and hyperuricemia. Okay, flushing because basically it's prostaglandin mediated. So how do you prevent this? You need to inhibit prostaglandin synthesis. So you have to inhibit the COX enzymes. Okay, so that means you have to take aspirin prior to niacin, and that can reduce this flushing issue, right? And there will be the inhibition of uric acid secretion. That is why you get hyperuricemia, and then that can progress to gout. Okay, so so it's better, it's contraindicated at gout or if you have hyperuricemia, right? And it's also contraindicated in peptic ulcer disease and active liver disease. Not niacin is not that important, but these things may be a little interesting to know. Right. So the summary, we've come to the final slide of our presentation. So final take-home message would be that out of all dyslipidemia, hypercholesterolemia is the most important, okay, because of the risk of atherosclerotic cardiovascular diseases, okay. So and the most effective cholesterol reducing drug for the majority of population would be statins, okay, statins, right? And fibrates, as you can see, mainly reduce triacylglyceride levels, and niacin increases HDL levels, even though it's not used that, it's not that famous now, but you need to know because it's targeted for HDL specifically, right? And so another thing that you need to know is that avoid the combination of statins and fibrates together because it can cause rhabdomyolysis in the patients, okay. And it's better to monitor CK levels, your INR, and your liver function tests like AST, ALT, especially with statins and fibrates. And the other important thing would be, now if statins are contraindicated, you go for bile acid resins, and now that is being replaced by ezetimibe, okay. Right, so that's pretty much. Thank you.